our topic about how to improve ICSI outcome in tubal factor infertility. At first, we should know the anatomy and physiology of fallopian tube. Fallopian tube is about 10 to 13 centimeter in length and about 0.5 to 1 centimeter in diameter. The channel of the tube is lined with mucous membrane, with a layer of mucous membrane that has many folds and papillae. Tubal fluid has a complex mixture of oviduct secretory proteins. It contains serum transudate, electrolytes, albumin, immunoglobulins, transferrin, and a specific glycoprotein that is released during ovulation, which is the oviductal glycoprotein, which has a role in fertilization. So the function of fallopian tube is gamete and zygote transfer to and from the uterus and fertilization in the ampullary part of the fallopian tube. So tubal pathology accounts for about 25 to 35% of female factor infertility in the form of either tubal block, either proximal tubal block or distal tubal block, salvangitis, which is maybe part of a PID or isolated salvangitis, and the last is hydrosolbex, which we face a lot in cases of recurrent failure or recurrent IVF failure. So hydrosolbex is defined as distally occluded, dilated, fluid-filled fallopian tube. Distally occluded, fluid-filled. It's found in about 10 to 30% of couples with infertility. Hydrosolbex is a form of tubal damage. So the lining endothelium is damaged, so it can't absorb the fluid secreted inside the fallopian tube. Can be caused by intrinsic or extrinsic inflammation, either ascending salvangitis or from outside by peritonitis or endometriosis or previous pelvic surgeries. So does it have a bad effect on IVF outcome? Yes, of course. Studies found that the success of ART, especially IVF for patients with hydrosolbex, is reduced by half. Also, there is increase in the percentage of early pregnancy loss and percentage of ectopic pregnancy in cases of hydrosolbex. So what is the mechanism? The exact mechanism is still unclear, but there is theories it could be related to mechanical effect of hydrosolbex fluid or toxic effect of fluid on the gamete or zygote, alteration of endometrial receptivity by the fluid of hydrosolbex. A study showed that hydrosolbex fluid, if compared with blastocyst culture media, we found that hydrosolbex fluid has a higher pH and lower level of potassium, calcium, magnesium, and glucose level. So it is deleterious for gamete and zygote. Also, it have an effect on embryogenesis. If embryos cultured in hydrosolbex fluid, they found that there is reduced development and of embryogenesis, and this effect is increased by increasing the concentration of hydrosolbex fluid. So hydrosolbex fluid has effect on embryogenesis, so it affects the development of embryos inside the tube. Also, it has bad effect on the pelvic vascularity. Studies showed that hydrosolbex is associated with impaired endometrial and ovarian blood flow, which may adversely affect the endometrial receptivity and the oocyte quality. So, when to suspect or which patient does I screen for hydrosolbex? Patient with a history of PID, endometriosis patient, previous pelvic surgeries, recurrent implantation failure, or you may find hydrosolbex accidentally during your ultrasound scan for infertile patient. Diagnosis of hydrosolbex. First, hysterosalpingogram is useful for diagnosis communicating hydrosolbex, not diagnosis of hydrosolbex. So what is communicating hydrosolbex? Communicating means that hydrosolbex communicate with the uterine cavity. So there is no block or no corneal obstruction in this place. So hysterosalpingogram is useful for only diagnosis of communicating hydrosalpinx. But the conclusive or the diagnostic test is 2D ultrasound. You can see this shape, it's characteristic for hydrosalpinx, which is sausage-shaped, fluid-filled structure near the ovary. You may have septation inside this cystic structure. So the conclusive diagnosis is 2D ultrasound. And then you do hysterosalpingogram to confirm communication between uterine cavity and fallopian tube. And the last, you do laparoscopy for confirmation of diagnosis and management. So this is ovary and this is the fallopian tube showing hydrosalpinx. So you suspect when you do follicular scanning and you find this sausage-shaped beside this ovary, so the diagnosis is hydrosalpinx. So you diagnose hydrosalpinx and you are preparing a case for IVF. So what is your management? A study was done showing management for hydrosalpinx in many ICSI centers in Europe. It showed that about 67% of centers doing laparoscopic salvangectomy, about 1.8% doing salvangectomy by laparotomy, not laparoscopy. So it's a very minute percentage. Also about 20% doing salvangostomy, only drainage of the hydrosalpinx. About 9% only doing proximal tubal occlusion by laparoscopy. About 81% giving antibiotics, and about 18% giving antibiotics with corticosteroids, and about 12% doing ultrasound guided aspiration. So we'll discuss with each point. First, salvangectomy. What is with and what is against? Salvangectomy is useful because it decreases the risk of infection after oocyte retrieval. So by removal the fallopian tube, you avoid entering by your needle inside the fallopian tube. So decrease the risk of PID or infection after ovum pickup. Also decrease the risk of adnexal torsion. If you look to the distended fallopian tube, which is disconnected from the uterine cavity, so it's free from both ends, so it can twist easily, especially with enlarged ovaries. So by removing the tube, you avoid the risk of adnexal torsion. Also increasing the accessibility of the ovary, because huge tube may distort the anatomy, so it make ovum pickup very difficult. Also, it improves the outcome of ICSI after salvangectomy. But on the other hand, what is against? Negative effect on ovarian reserve. So after ovarian stimulation, it may affect the response. It decreases the number of oocytes, decrease the number of embryos, decrease of the cryopreservation or vitrification rate. Also, it could be challenging, especially in cases like this case. You go for bilateral tubal ligation, you found this tube easy, but the left tube is embedded within adhesions, ovarian and colonic and uterine. It's very difficult to do salvangectomy in this case, so you only do tubal disconnection only without doing salvangectomy. So the drawbacks of salvangectomy: difficulty in cases like this, and decreasing ovarian reserve or decreasing the outcome after ICSI. So a lot of studies has done to compare, to show the effect of salvangectomy on the IVF response. Some studies said yes, it decreased AMH and decreased number of oocytes. On the other hand, two studies said no, there is no adverse effect on IVF response. And one of these studies, it was a meta-analysis in 2016. This is a recent meta-analysis in 2019. It showed that the number of retrieved oocytes and total FSH dose between salvangectomy group compared with non-salvangectomy group were similar. So there is no harmful effect of salvangectomy on the outcome of ICSI. Also, live birth rate, clinical pregnancy rate, implantation rate in salvangectomy group were higher than the non-salvangectomy treated group. So this meta-analysis, which is a recent meta-analysis, showed that there is no harmful effect of salvangectomy on the outcome of ICSI. This is a chart showing there is no effect on the number of retrieved oocytes. Also, on dose of FSH, there is no difference between a salvangectomy and non-salvangectomy group. On the other hand, implantation rate was in favor with salvangectomy group. Also, clinical pregnancy rate was in favor of salvangectomy group. So salvangectomy improved live birth rate, clinical pregnancy rate without affection of retrieved number of retrieved oocytes or the total FSH dose needed for this cycle. The other option is laparoscopic proximal tubal occlusion. A meta-analysis showed that the ongoing IVF pregnancy rate of proximal tubal occlusion and salvangectomy were superior to no intervention. So it is comparable to salvangectomy and it was superior to non-intervention. Another study comparing salvangectomy with tubal occlusion only, it was done on 106 patients. It showed similar ongoing pregnancy rate in salvangectomy and proximal tubal occlusion. Also, meta-analysis show a similar clinical pregnancy rate and similar live birth rate between salvangectomy and proximal tubal occlusion. The recent meta-analysis showed the same result. It is technically less demanding, so it can be used in difficult cases. May be considered a valid alternative to salvangectomy in Hydrosolbex treatment, especially in one with severe periadnexal adhesion, in order to decrease the morbidity for the patient. The third option is ultrasound-guided aspiration of Hydrosolbex fluid. Randomized trial done on 160 patients with ultrasound diagnosed Hydrosolbex aspiration compared with salvangectomy. Ongoing pregnancy rate were similar to salvangectomy, but a sector of these patients has a rapid reaccumulation of Hydrosolbex fluid, and it affected significantly the pregnancy rate. So ultrasound-guided aspiration may be useful, but it has a higher reaccumulation rate, which may affect, or it affected really the pregnancy rate if compared with salvangectomy. The fourth method is sclerotherapy. After you aspirate the Hydrosolbex fluid, you measure, it's about 15 millimeters, so you inject absolute alcohol, half the dose. If you aspirate 15 millimeters, so you inject 7 millimeters, wait for 5 to 10 minutes, then aspirate. Give antibiotic, prophylactic antibiotic. This is sclerotherapy. You do damage to the endothelium, so there is no reaccumulation of Hydrosolbex fluid. Sclerotherapy is considered successful when the fallopian tube contains no fluid or less than 10% of the previous amount of fluid. This is after 2 weeks from the procedure. Efficacy, it has a similar clinical pregnancy rate and comparable miscarriage rate if compared with salvangectomy, but it has a higher level of complications. It leads to abdominal pain. If ethanol leakage into the abdominal cavity, it's very painful, may lead to ethanol intoxication. Also, pelvic adhesions and infection. Recurrence of Hydrosolbex occur in about 20%, which is a high percentage. Another method, which is not recommended now for usage for blocking treating Hydrosolbex, which EFRE system. This device has been withdrawn from the market in some European countries and USA and Canada. Also, the use of EFRE system before IVF is off-label use because it's only a contraceptive coil inserted inside the fallopian tube, not for treating Hydrosolbex. A meta-analysis showed that live birth rate, cumulative birth rate after EFRE treatment was significantly lower if compared with salvangectomy or other surgery. So EFRE isn't effective in treating cases of Hydrosolbex before IVF. Complication of EFRE system, EFRE placement associated with pelvic pain, which may necessitate removal of this device. Also, there is complication related to pregnancy, such as dislocation due to dilatation of the fallopian tube. Also, embryotoxicity of the nacal within the system. Also, negative implantation effect due to the coil inserted. So, if you will do laparoscopy for either salvangectomy or proximal tubal occlusion, you should consider low voltage or low power of the electricity or of the bipolar before cutting the tube or before occlusion the tube, because the heat or thermal effect or thermal damage of the bipolar may go to the ovarian vessels and it affect the ovarian reserve. It affects the outcome if you put the electricity for a longer time or with high power. So decrease your voltage, decrease the power of the device in order to spare the ovary. And stick to the mesosalpinx, stick to the fallopian tube. Don't touch the ovary. Outcome after surgery in a Cochrane meta-analysis involving 646 women in a 3 randomized controlled trials showed that higher ongoing pregnancy rate in pre-IVF treatment group compared to no treatment. The benefit seemed to be higher with Hydrosolbex, which is bilateral and visible on ultrasound. So there is improvement after surgical correction of Hydrosolbex before IVF. So if you do salvangectomy or proximal tubal occlusion, when to start your cycle of ICSI? This study compared 3 groups. Group started in less than 10 weeks, second group within 10 to 16 weeks, and the third group in more than 16 weeks. The higher pregnancy rate, the higher clinical pregnancy rate and the implantation rate was in the second group, which is between 10 to 16 weeks after the surgery. So you should wait from 3 to 4 months after doing salvangectomy or tubal occlusion, because the effect of surgery, because of the effect of diathermy and necrosis of tissues may make inflammatory environment which may be hostile for implantation. So wait at least 10 weeks before embryo transfer in IVF cycle. So our conclusions: Hydrosolbex affect IVF outcome. It decreases IVF outcome about half or 50%. Salvangectomy is the first choice. Plan B, proximal laparoscopic tubal occlusion. Plan C, no hysteroscopy. I invite you to attend EFRE next webinar next week on 4th of September, which is on the controversy in ART practice. Thank you for your attendance. Waiting for your questions.